So I was asked to speak today on this is what I want from my revascularization colleagues. So realistically, when we look at our current wound healing guidelines, the ACC guidelines suggest that wound healing for patients with critical limb ischemia should involve an interdisciplinary team that evaluates, provides comprehensive care for the patient with CLI and tissue loss to achieve complete wound healing and a functional foot. And that after we get our revascularization, wound healing progresses with the intent of complete wound healing and again, functional ambulation. It suggests that patients with CLI, revascularization is done to minimize tissue loss, and that evaluation by an interdisciplinary team before amputation is really warranted. And that's all well and good. It also goes on to say, well, who is that care team? And it gives us recommendations. That care team is very much a multidisciplinary team, and it includes the vascular specialists, but also nurses, orthopedic surgeons, endocrinologists, internal medicine specialists, and the list goes on. So realistically, from my approach, when you have a true wound healing team, it takes a village, right? And there are a lot of people that we work with every single day. From a professional standpoint, we work with vascular medicine, podiatry, vascular surgery, plastic surgery, general surgery, internal medicine. We rely on our reperfusion specialists, including cardiology, vascular surgery, and radiology. There's a lot of ancillary medicine support. We rely on the internists. We need to have their support. Infectious disease, endocrinology for our patients with diabetes and nephrology, rheumatology, and then surgical support outside of that from orthopedics, podiatry, colorectal, plastics, the list goes on. But even more importantly, we have all of our other ancillary support, and this is all equally important. So the professionals at the top sometimes don't remember that there's a lot of nursing support that goes in. We are critically dependent on the information we get from our vascular laboratory technicians. Home health care and DME, which every patient really relies on. Our orthotists, our pet orthotists, and our prosthetists, who we don't have as much contact with, but you certainly have to have a good one. And if you don't have a good one, life becomes much more difficult. Our dietitian, nutritional counseling, our physical therapists, our lymphedema therapists, and then above and beyond that, at the end of the day, right, there's our administrative support, our billers and our coders, and even our environmental support that has to get involved to make sure everything goes smoothly. So realistically, we have this really nice idea of what our team is. When we're in the wound clinic, this is what it looks like, right? There are days when it really seems like complete chaos. Now, at the end of the day, it all gets done. Our patients benefit from our care. But we're left with this, right? And so at the back side of this, what do we need from all of our other support people? Well, we need a little help. We need communication, right? So what do I need from my revascularization colleagues? I want to know if and when a procedure is planned and any anticipated delays, right? If I tell my patient, you're going to see somebody next week, and next week turns out not to be next week, I need to have an explanation for that. What's the referral process? How do I get somebody in if it's an acute limb versus if it's critical limb ischemia, where time is still of an essence, or if it's more of a routine procedure, and I need an angio, I need runoff, I've got somebody who may just be a claudicant, et cetera. Is there a contact person? Is there a process? Do I go through the NP? Do I go through the secretary? Do I go through the cath lab? Do I have to call directly to who knows who? Do you want to see the patient first? Obviously with ALI and most of the time with CLI, that's not necessarily always feasible, but do you want to see somebody first if it's an opportunity? And when the patient comes in on your service or comes into the hospital, who's primary on the service? Do they get admitted to medicine? Is there a cardiology team? Is it the interventional radiologist bringing the patient in and it goes to the unit? Who's my main players? And please, please, please notify me when my patient is in the hospital, because even if I'm not consulted, even if they don't need me that day, I will stop by and say hello, right? I see these patients every other week or every 3 weeks, and it's important for them to know that I'm still involved. On the other side of that, back end of the procedure, keep me in the loop. Was the procedure successful? Do I have inline flow? Do I have angiosome flow? Even better, right? Or do I have a very tenuous runoff where I have to be worried about that toe, that forefoot, that revascularization every time I see the patient. What are the recommendations that the patient's going to be following after the procedure? Is the patient on DAPT? Did they require anticoagulation? How long would you like to have that on board? Are we looking at 3 months or 30 days, or is this something that, because it's very tenuous, should be indefinite? What are the surveillance requirements? So if the patient falls off that surveillance pathway, I can get them back on. But if I don't know what it is, I can't help. And what are required labs? If you think you may have used a little too much contrast and I need to look at the kidney function, please let me know. If there was a little extra hemoglobin left on the floor at the end of the day, let me know. I will take a look at the CBC. I'll make sure we're all on the same page. Should there other procedures be delayed for some reason? Did you do something that you don't want me to immediately debride this patient or immediately send them to amputation or anticipate doing any other grafting or anything else? Because I can generally wait, but I need to know. And did something unplanned happen? Nothing worse than having the patient come back and say, oh yeah, Dr. So-and-so said this happened. And if I don't know about it, right, now I'm going back. I'm trying to find the op report, I'm trying to find the note, something happened, something didn't go the way it should have gone, etc. So we have guidelines for follow-up, right? Unfortunately, these guidelines are very amorphous. We need to follow up the patient. That's really what they say, right? It doesn't give you time frames. It doesn't give you any guidelines or any structure. So again, communicate those anticipated guidelines and those anticipated follow-ups to me, and I will be happy to help. So at the end of the day, what do I want? What do I need? It really comes down to communication. Just tell me where you're at. So every team needs a captain. Every player on the team is important. Doesn't matter what the role that player is playing. Everybody at the end of the day has the same goal, and winning through limb salvage really is everything. To me, to the patient. I hate to walk into the patient and say, I lost the game, because we're going to lose a leg, a toe, a foot. It doesn't matter. I don't like to lose. So when I spend my day, like the left-hand side of the slide here, and then I give a handoff and I'm left standing completely bewildered with what happened, it doesn't leave me with very good feelings. So what do I need? That's what I need from my wound, from my revascularization folks. Thank you.